Hi, everyone. We are just going to wait about one more minute here to let a few more people in from the waiting room. I want to welcome you all to our June networking webinar. We will get started here at 10:01. Okay, hi everyone. Thank you for joining us today. I am just going to go over a few things before Alex goes through the webinar and introduces our presenter for the day. I wanted to let you all know that we do have subtitles on for this presentation to accommodate everyone. If you do not want the subtitles to show, please go to the bottom of your screen where you can mute and unmute yourself or start and stop your video. And all the way to the right, there is a button that says live transcript. And if you click that button, there is an option to show subtitle or hide subtitle. And you can hide the subtitles if you would like. If not, they will show on your computer for the entire presentation and be there for you. Please just make sure that you are muted until we have the Q&A, and I will pass this over to Alex.
Hi, everybody. Good morning. Thank you for joining us today. We're excited to have Dr. James Conway here with us for our presentation all about adolescent vaccinations. So we are delighted to have so many new people join us today along with our existing members. For those of you who may not be as familiar with us, we are the Wisconsin Cancer Collaborative, Wisconsin's statewide comprehensive cancer coalition comprised of 140 organizations working together to reduce the burden of cancer for everyone in Wisconsin. If you are not yet a member, we'd love to have you join. Membership is free. If you are interested in joining, you can do so at the link at the bottom of our screen. Here's the agenda for today's talk. We will go over a brief intro, and then we will have our presentation by Dr. Conway. We will have plenty of time at the end for questions, so feel free to drop them in the chat box throughout the presentation or save it for the end where you can unmute and ask. So with that, it is now my pleasure to welcome back and introduce our speaker today, Dr. James Conway. Dr. Conway is a professor in the Department of Pediatrics, Division of Infectious Diseases. His primary area of interest is centered on vaccine development and strengthening immunization programs, both domestic and international. He is medical director for UW Health immunization programs and is currently providing oversight for UW Health COVID-19 vaccine logistics, including storage and prioritization, as well as serving in the Emergency Operations Committee for the University of Wisconsin system. He is involved in multiple COVID-19 vaccine development programs, as well as serving on the Wisconsin State Disaster Medical Advisory Committee for COVID-19 vaccines. And with that, I will turn it over to Dr. Conway.
Thanks, Alex. Let's see if I can get this to work. Oh, okay, good. Everybody can see the screen. So I just wanted to quickly start out. I think everybody's well aware of kind of where we are, but I wanted to make a couple of points about where we are within the pandemic before we start talking about the various vaccine challenges. This is courtesy of the New York Times from yesterday and just gives you a sense for what we're all experiencing here with really a gradual diminishment in the number of reported cases, as well as drop-offs in hospitalizations and deaths across the country. And I think this is a credit to a lot of things, including our wide-scale vaccinations, as well as the number of people that have survived and have at least some natural immunity from the infection. Oops. This gives you just a sense for what it's like to be an unvaccinated person and what the risks are put together by Johns Hopkins and the CDC for where you live in this country. And I think it's just interesting that the risk is basically predicated on how many unvaccinated people there are, along with how much disease circulation there is. And so even though we are at relatively low rates of disease nationally, you can see that in many of these areas, that are holdouts on vaccine, that those are continuing to be the areas where we have most of the disease. And so you can see that here in Missouri, West Virginia, then large areas of Wyoming, Idaho, areas that are tending to be more vaccine hesitant or vaccine opposition are the areas that are continuing to be the areas that unvaccinated persons are at highest risk. And then, our topic today is adolescents. And, the reason that this is kind of the lead in is because what we have seen over these last few months is adolescents more and more bearing the burden of this disease, as they are the group that are only most recently being able to get vaccinated. And so this is CDC data from March through April. Got to be careful with my mouse. How do I go backwards? Let's see, hold on one second. Well, now this basically kind of tells the same story, but what this is a comparison of is, when people keep trying to allude to the fact that, for vaccine opposition groups, that COVID is basically a bad flu. This gives you a sense for where flu was over the last couple of years for adolescents compared to where COVID-19 is. And so about a third of the cases now currently are young adults and adolescents, and we're seeing more and more hospitalizations in that age group, as well as increasing severity of disease as we see more variants introduced into the country. Now, where are we with vaccines? So as people are well aware, back in March, April, May, when we were still in the throes of major disease transmission, we really reached a peak of almost 3 million doses a day. As things have improved and more people have already been able to be vaccinated, we've settled in on a rate of around 1 million doses a day. One of the things that's very interesting that many of us were concerned about is when the CDC lifted the masking mandate and indicated that vaccinated persons could drop their masks. I think everybody was concerned that that would basically shut down vaccines as well, and that people would essentially just all start acting the same. And I think it's actually been interesting that you saw sort of less and less uptake of vaccines over time. And right here is actually when the CDC issued their new guidance. And you can see that it basically led to sort of a leveling off. And I think that one of the things we were becoming a little bit more optimistic about is that at least many people seem to be understanding the messaging that you can really remove your mask safely only if you're vaccinated. And so finally, there's some version of an incentive that does seem to have gotten people that were sort of on the fence to actually continue to get vaccinated. Now, here's where we are in the state of Wisconsin as of yesterday. This is 1-dose data, but you can see that almost half of the individuals in the state that are eligible have received a dose of vaccine. And this is all from the Wisconsin DHS COVID-19 website. I encourage people to look at it pretty regularly. And there's a couple of encouraging things here. One is that the biggest uptake of vaccines across the United States, but and particularly in Wisconsin, has been the increased immunizations being seen in the Hispanic and Latinx populations, which have been up about 28% over the last couple of weeks. And then the other is obviously this interest in immunizing in the young adults and adolescents has at least started to move in the right direction, although still quite a ways to go when you're looking at these adolescent populations, where only about a quarter of them so far as of yesterday had received a dose of vaccine. You can also see how disparate the distribution is, that the leading counties, Dane County actually was #1 in the whole country for immunization rate, which we're very proud of here because of the collaborations across the county. We meet actually weekly with all the health systems and public health weekly to try to coordinate our programs. Door County, interestingly, being the other one. But you can see that there's areas of the state that are largely unvaccinated or lower vaccination rates. And so this is not equitably distributed. And as I mentioned, the most recent addition to the ability to vaccinate is in our adolescent group, where the 12 to 15-year-olds have recently been added. And so you can see this is CDC data from yesterday, that in the last 14 days, the largest numbers of people being immunized are actually in the 12 to 15 group. But I think we're pleased to see that we're also continuing to see more and more uptake in the young adult populations. And so that's encouraging, because we've done a really good job of immunizing in these older populations, but starting to see increasing interest and increasing movement in the younger groups, I think, is encouraging. Which vaccines are being used? Obviously, as everybody is aware, the Johnson & Johnson pause, which had been really a vaccine that was of interest to a lot of people because it was one and done, really led to a significant drop off and has not really picked up very much nationally. The workhorses continue to be Pfizer and Moderna, and you can see that Pfizer has jumped up here because of their being the only available vaccine for the 12 to 17-year-old age group. And so they've picked up quite a bit recently with that interest in immunizing adolescents and young adults. At the rate we're going currently, while the Biden administration has expressed a desire that we're going to have 70% of people immunized by the 4th of July, unfortunately, this drop off and leveling off of vaccination forecasts that we will probably not reach that 70% mark until sometime in mid-October, and won't even get to the 80 or 85% rates until we get into 2022. So there is still a lot of need to be messaging and reaching out to people to encourage vaccination, especially in this young adult population. So here's where we are currently with vaccines. So the the 3 vaccines that have emergency use authorization, Pfizer is authorized now from ages 12 and above. That was just issued on May 10th. Moderna just submitted its data today for the 12 to 17-year-old age group, and so we expect some movement on that in the next few weeks, and anticipate that that will probably receive its emergency use authorization by the end of June. This was sort of something that we were a little bit more eager about because Pfizer had pretty strict freezer requirements, and Moderna was a lot more flexible on the ability to provide decentralized vaccine delivery. Pfizer, in addition to getting the EUA to lower the age to age 12, also got an amendment that their vaccine is now also allowed to be kept in refrigerators for up to 31 days. And so that has made things a lot easier. And so I guess our eagerness to get Moderna out there isn't quite what it was now that Pfizer can be kept in refrigerators. And so this has really been one of the major moves in the right direction, is the ability to decentralize the administration of these vaccines. The other very important thing, obviously, that happened was the lifting of the ban on any co-administration of vaccines. And so the ability to now give the COVID-19 vaccine along with other routine vaccines, and I'll talk more about that in a few minutes, has also been really exciting. So basically, we've got 3 vaccines now that are available: Pfizer, Moderna, and Janssen. Pfizer and Moderna 2 doses, Janssen single dose. Interestingly, what we've started to see happen over the last couple of weeks, I think, is very interesting. Pfizer continues to be the workhorse, again, largely because they're approved for adolescents. But in sites that allow people to choose their vaccine, Pfizer and Janssen are actually the leading vaccines, that they're 1 and 2 very closely in a horse race. And the thought is that there's a lot of these folks that were sort of on the, I'm willing to do it, but you need to make it more convenient, who, despite those warnings about clots and all those issues, have actually been very willing to get the Janssen vaccine. And so at most of the sites, for instance, here at Public Health Madison, Dane County, where they do allow choice for vaccine at their immunization sites, Pfizer is number 1, Janssen is a very close second, and then Moderna is 3rd. Now, where do we stand with parents and their attitudes about adolescent immunizations? This is Kaiser Family Foundation has done a really nice job throughout the pandemic of doing monthly surveys on attitudes. And so they've only been surveying attitudes about adolescent vaccines for just the last couple of months. But you can see back here in April, right after we had at least initially vaccine being available for 16-year-olds, but not yet available for the 12-year-old group, that a very small group of parents were eager, wanted it right away, but there was a fair amount of people that were sort of in the wait and see or only required. Once the vaccines became available and more individuals have been vaccinated, you're starting to see people more eager to get moving on this, and this wait and see group kind of shrinking. And similar to what we've seen in the adult population, where about 7 or 8% of people have been absolutely not, that stays, at least in the adult population, quite stable. And so most of the people are sort of in this, I'll do it if it's required, or I'm going to wait and see, but I'll probably do it eventually. So we're hopeful that in the adolescent group, as more data becomes available and more adolescents are vaccinated, people become more comfortable, and hopefully we can get this definitely not group to shrink. But 4 in 10 parents already say that their kid has either been vaccinated or they're going to do it as soon as possible. Now, what's on the horizon for COVID vaccines? As usual, there's all sorts of things coming down the pipeline. So both Novavax and Sanofi, with a collaboration with GSK, have kind of old school vaccines coming that are, I'm guessing, probably going to be submitted for emergency use authorization when we get to sometime in the third quarter in the early fall. These are both, as I said, old school. They're basically protein subunit vaccines. So I kind of equate these to the sort of typical inactivated flu vaccine model, where they basically just have pieces of the protein, the spike glycoprotein. The Sanofi vaccine has also a little bit of an adjuvant that was provided by GSK. And so if there are people that are concerned about this genetic technology that all 3 of the other vaccines use, the mRNA technology, this will at least be available pretty soon for people that, for whatever reason, want the old school version. Janssen is progressing with their 12 to 17-year-old studies. We're expecting to see those out in the next couple months. When I wrote these slides yesterday, Moderna wasn't quite sure when they were going to submit their data, and then they did it overnight. So they actually submitted this today, and the FDA is going to be reviewing that. And then both Pfizer and Moderna are in their dose finding measures for the under 12-year-olds. And so you may have seen some press releases, and yours truly on the TV and radio yesterday talking about the progress with these. And interestingly, Pfizer's data shows that they actually really can get away with a much lower dose of antigen to actually get decent immune response in younger kids. And so hopefully this will be reassuring to parents that for the 5 to 11-year-olds, they're going to be testing a 10 microgram version, which is about 1/3 of the antigen that's in the adult version of the vaccine. And for the 6-month-old to 5-year-old group, it's going to be about 1/10 of the amount that's in the adolescent vaccine, so only about 3 micrograms. So it turns out you can get away with a lot less antigen to stimulate the immune system. And hopefully that translates into a lot less side effects, because that's been one of the concerns in the adolescents and young adults, is that with a really powerful immune system, they do sometimes have a little bit more in the way of side effects from the vaccines. And then these are going to move, now that they've done the dose finding process, are moving into these large scale safety and immunogenicity trials. And so we're hoping to see data for the 5 to 11-year-olds probably in September or October. And so potentially being able to start immunizing with a different vaccine product in those elementary school age kids sometime this fall. And then the other sort of exciting news is that both Moderna and Pfizer are in the process of what's called a rolling submission with FDA, where they're basically submitting their data in kind of big chunks now that they've got a full 6 months of data from a large population in the search for a full biological license from the FDA, which many of the people that are sort of in the wait and see group say the reason they're going to wait is that they want to wait until it's a fully licensed vaccine. They've both indicated that they're seeking priority review from the FDA. And so the FDA hasn't answered whether they're going to grant that or not. As people may know, the typical FDA review after the full submission is done is that they have to answer it within 365 days. And typically that's actually what they've done for most vaccines over the last 30 years, is somehow they wait until the very last second to get their homework done. We are hoping that for the first time ever, they'll actually provide a priority review for a vaccine. And so that we may have full licensure of these things potentially also in the fall. And hopefully that'll then continue to get people off the fence before we get into the fall and winter months, when people are worried that if this is truly going to be an endemic disease that is going to circulate, it's going to probably circulate in fall and winter flu and cold season the way most other respiratory viruses do. So we'll have to see what happens there, but I think we're pretty optimistic that those licenses should be issued by the end of the year, certainly, if things go well. Now I want to shift for a second and just talk a little bit specifically about cancer patients, because there's been some very interesting and mostly exciting news coming out of the cancer research side of things in relation to COVID-19 vaccines. First off, just to remind people what the current FDA and CDC guidelines are, which is that currently authorized COVID-19 vaccines can be administered to persons with underlying medical conditions who otherwise don't have a contraindication. And that includes everybody with immunocompromised conditions, people with autoimmune conditions, people with all sorts of history of various immunologically mediated problems. And then basically the statement from both organizations is that the clinical trials included persons with underlying medical conditions, including people with cancers and other immune compromising conditions, and that the safety and efficacy profiles were fairly similar to those without underlying medical conditions. And so the guidelines have really been to encourage vaccination in all groups, regardless of comorbidities. There's been a couple of interesting studies that have come out just in the last couple of weeks that I thought many people on this call might be interested in. Two of the big ones, because Israel was early in the groups that were able to immunize broadly across their population. And Israel primarily used Pfizer's vaccine, which is this BNT 162b2 mRNA vaccine. And so interesting opportunity then, because if you've got a country that's primarily using one vaccine and they got up to about 80% immunization coverage rates fairly quickly because they paid top dollar to be on the front of the line to get vaccines, they were also able to then study some populations of interest. And so they recently published just at the end of May in JAMA Oncology, 102 cancer patients undergoing therapy who received the Pfizer vaccine, and 90% of those cancer patients were fully seropositive after their second dose, compared to 100% seropositivity in healthy control populations. But really very encouraging that, in fact, most cancer patients seem to respond quite nicely. A different study looked at chronic lymphocytic leukemia patients, where they measured antibody titers. And this, at least in the media, was picked up as being not so great because it was an overall response rate of only about 40%. But the exciting part here was actually that for patients that were in remission or patients that hadn't been treated yet, they actually had pretty good response rates. The group that really dragged the numbers down were those people that were actively on treatment for their CLL. So that it actually turns out that immunizing these patients certainly doesn't lead to any unexpected side effects, but actually does offer pretty decent protection against, especially for those that are in remission. Now, the other stuff that's gotten a lot of press over the last couple of months that I just wanted to share, even though it's not directly related to your populations, was the data that came out after solid organ transplants, who, in a large study that looked at people receiving one of the mRNAs, about half received Pfizer, half received Moderna. They didn't get great antibody responses after the first dose, but actually did better after the second dose. And interestingly, as long as they weren't on mycophenolate or azathioprine, which are antimetabolites to suppress their immune systems, they actually responded quite nicely. So it turns out that for transplant patients that are maintained on just prednisone or tacrolimus and non antimetabolites, that they actually do respond pretty well. So it turns out that it's certainly worthwhile to immunize these patients, and at least many of them are going to get some benefit from it. Just a couple cautionary statements to remember about all of this information. One of the things we've seen a lot of patients and providers doing in various oncology patients and transplant patients is immunizing and then sending antibodies and being a little wigged out over the fact that they have negative antibodies. And people need to remember that most of the commercial antibody detection is actually not for antibodies that you would generate from vaccine, but rather from they're generated against a nucleocapsid antibody. This was intentional when these antibody assays were developed early in the pandemic, because everybody knew that there would be vaccines coming, and all the vaccines are basically designed around the spike glycoprotein. And so intentionally, most of the commercial assays measure for an antibody that you won't develop if you're vaccinated. You'll only develop it if you have the disease. And so we've seen a lot of requests recently, especially to or from oncologists, wanting guidance on boosting doses of vaccine for their cancer patients. But it turns out most of them are using a nucleocapsid antibody that doesn't give you any information about the vaccine immunity. And so vaccines, I just need to remind people, only will provide spike glycoprotein antibodies. The other thing that's becoming more and more apparent is that while the antibodies are easy to measure and they're what we're used to measuring, it turns out that T and B cell memory immunity is probably as important, if not more important. And the reason we're finding that out is because we're seeing people that recover from the disease. And if you have mild disease, many people actually lose their antibodies over a 3 to 6 month period. And yet it's pretty clear that they're still protected against infection. And it's probably related to the fact that they actually have pretty good T cell immunity. I mean, there have been a couple of small studies that I've seen data from where they've taken bone marrow donations that were brought and actually tested the T cells in people that have actually had previous COVID infections. And it turns out that even in people that have negative antibodies, they have very robust T cells from those stem cells. And so it turns out that they actually probably do have pretty good residual immunity. The other thing is that we have to remember that there's really no particular level of antibody yet that we've sorted out that actually even correlates with immunity. And so this is one of the things that people need to be careful about. Even if you do measure spike glycoprotein antibodies, the fact that they're low doesn't necessarily mean that they're not protective. It just means that they're low. And so currently, and we can't emphasize this enough, there are really no recommendations for booster doses beyond the primary series in any populations. And while ultimately I think boosters may be needed eventually, it's not clear whether those boosters are going to need to be different vaccines or whether just giving a boost with the same vaccine we're currently using will be sufficient. And in fact, there's preliminary data from both Pfizer and Moderna that shows that if you just give another dose of their original vaccine, it actually boosts the immunity enough that we do quite well against what used to be called the B.1.1.7, or now it's called the Alpha strain, or the Indian variant, the Delta strain, that just by giving an additional dose of the original vaccine gets you antibodies at a high enough level that they actually do just fine with those variants. And so this is sort of in the to be determined, but what we don't want is people just willy-nilly giving booster doses and then essentially missing the opportunity to give either an updated version of the vaccine or giving the booster dose at a better timing. There's more and more data that suggests that if you wait longer to give boosts, that actually may be a better boost than if you give it too quickly. All right, so then I want to transition into talking about the impact of this whole pandemic mess on routine immunizations, and in particular, I'm thinking about HPV as our other major vaccine, in addition to the hepatitis B vaccine, as two of the other ways of preventing cancer. I've got a couple of slides here, courtesy of Wisconsin DHS, that I think are interesting and worth thinking about. So this is basically the change of what's happened with routine vaccines across all age groups in Wisconsin throughout the pandemic. And so if we take 0% as sort of the baseline normal amounts of vaccine, you can see that we've done a pretty good job in the 0 to 24-month-olds of maintaining their vaccines, although they're still 10 to 15% down from where they usually are in an average year. But you can see for other age groups, in particular for 5 to 18-year-olds, that vaccines are way off, and that there have been consistently over many, many months, people missing out or deferring or delaying vaccines. And so we've got a lot of catching up to do. Here's a couple just drilling into that a little bit and looking at the age groups of interest here for adolescents. So this light blue bar is basically a 5-year average of 2015 to 2019. And you can see by month, starting in February here, and then during back to school time over the summer, the typical surge, and then we sort of see a typical surge in October that goes along with when people are coming in for flu vaccines. That's also a time that other vaccines get caught up. Also when notices get sent home from schools that people are behind on their vaccines, and then people finally get scheduled to get caught up. This purple bar for these 13 to 18-year-olds is where we've been throughout 2020 during the pandemic. And you can see that we were way off during the spring, that there was a little bit of back to school catch up, but not nearly filling in this deficit. And then, really no catch up whatsoever. And so there's some data out in the last couple of days that we're down probably 20 or 25% on routine vaccines across the board for the 13 to 18-year-olds. And similarly for a larger group, 5 to 18-year-olds, the 5 to 18-year-olds did have, the 5 to 13-year-olds did have a little of this catch-up vaccination, but it didn't happen in the 13 to 18-year-olds. So we've missed out on a lot of vaccines. And so reminding people, there's basically on the 2021 schedule, there's sort of 3 routine vaccines, Tdap, meningococcal, and HPV, that are recommended at age 11 and 12, and then a booster of the meningococcal vaccine at the 15 and 16-year visit. And so these are kind of the 2 adolescent platforms when we typically see kids coming in, young adults coming in for vaccines. And this is just a mapping of before the pandemic, how we were doing nationally with those adolescent vaccines. So this is Tdap, which by far leads the pack of these three vaccines, head and shoulders above everything else. Here's meningococcal one-dose vaccine. You can see things were going pretty well. Here's our one-dose HPV vaccines, where we were only at about 65% nationally. Here is our HPV. Let's see, I got to look. So here's two-dose meningococcal vaccine, which was the new addition in adding that second dose. And about half of kids have gotten that. And then here's our HPV completion series. So this was back when it was a 3-dose series, and we were only reaching about 35% of kids. In 2016, ACIP adjusted the recommendations and said that as long as you got your first dose before age 15, that you only needed 2 doses. So that made the data look a little bit better, but we're still sitting at only about 50% of kids, young adults, having completed their HPV series. And so way off from our Tdap and meningococcal vaccines. Tdap is now routinely recommended and required for school entry for middle schools across the country, with South Dakota being the very last state that finally added that in 2017. Meningococcal, nowhere close to that. And you can see that Wisconsin, unfortunately, has been a holdout on school requirements. And only recently has there now been some movement, finally, after getting through some of the political log jams up on State Street, that there is finally going to be introduction of a meningococcal vaccine requirement in Wisconsin. But you can see that all of our surrounding states not only were requiring 1 dose, but actually have been requiring 2 doses for some time. And so, it's interesting that meningococcal rates are pretty close to Tdap, partially because it's just such a scary disease, but it's just remarkable to me that it's such a rare disease with, less than 1,000 cases a year, even before there were vaccines, compared to HPV, where there's, 20,000 plus cancer cases alone every year and millions of new infections every year. And so this is where our HPV mandates for secondary schools exist, with basically just Hawaii, Virginia, and I think Rhode Island being the states that currently require it. And so HPV, is way behind and really does need a lot more outreach and a lot more push to get people to accept it, which again is both sad and kind of shocking given how common this is, as all of you know. We don't have the 2019 or 2020 data yet from DHS because they've been a little busy with this pandemic thing. But just to give you a sense for kind of where we are Wisconsin wise, the darker blue obviously indicates higher immunizations rates. Again, this is up to date by 13 to 18 years of age. And you can see that, there's a fair number of counties that were at least over 40% of the groups immunized, but still a long way to go to be considered a adequately protected area. And then finally, some more information out from New York Times a couple of days ago, just reminding people that COVID isn't gone, and while it seems to be sort of quieted down temporarily, we are seeing not only higher risk in areas that are low vaccination rates, but hospitalizations rising in those areas of low vaccination rates. Data out today from Tennessee, where they have areas of the state that only have about 20% of the population immunized, show a 700% increase in hospitalizations in those areas related to COVID. And so it's clear that vaccine is really our pathway out of this pandemic, and really still is going to be the sole means that we protect people. And so finally, just reminding people that all oncology patients should be vaccinated against COVID-19. Certainly, the guidelines are out for stem cells, that the pre-transplant vaccination is encouraged for people that are potentially undergoing transplants, and I think that probably would hold for stem cell transplants as well. But the most important really for oncology and other immunocompromised patients is to really encourage vaccination in their household members and people they're going to be in close contact with, in caregivers. And we've even heard of many oncology patients advocating to their coworkers, for people that have to be back and in person, is basically asking, pleading, begging their coworkers to also be vaccinated as a means of protecting those that can't be completely protected themselves. And then encouraging oncology patients, because we're not sure how each of them might respond to vaccine, and understanding the data from Israel, that there certainly may be people that may be less optimally protected, that are oncology patients need to remember that even though the mask mandates have been dropped for healthy vaccinated individuals, that they should consider, at least in certain circumstances, continuing with protective masking and social distancing regardless of their vaccination status. Yeah, so sadly for them and for many others, masks will continue to be a necessary part of this, but I think that that's not necessarily a bad thing, that even with vaccination against COVID, that they still are vulnerable to other respiratory viruses. And we certainly saw that influenza in particular diminished quite dramatically just by these social distancing and masking behaviors. And so I think that, as we've seen in the past, many oncology patients had adopted masks anyway, and I think that that is still something that now is more clearly a benefit to them in addition to being vaccinated. So I thank you for your attention. Thanks for the opportunity to speak to your group again. I have a lot of admiration for Beth and her team, who really do a great job of communicating and sharing great information with their networks, and happy to take whatever questions you may have.
Great, thank you, Dr. Conway. Please, I know Dr. Conway was really excited to answer questions, take any feedback. So if there is any thoughts, absolutely wonderful presentation. So I will say I am a mom of a 12 and 15-year-old getting their second COVID vaccine today. So this was very timely information and helpful, and, reassures me that we were on the right path. And that as we have our last day of school today too, that hopefully next year we're gonna see a little bit more normal for everyone, including these kids, as they, try to go back to school next fall.
Yeah, I think that's the hope and the desire for everybody, Beth, is to, kids have really borne the brunt of so much of this. And, kids are not meant to be sitting in front of screens, and getting them not only to be back, but back hopefully soon without masks and to be able to really interact the way kids need to interact, I think is really important. I see one question. Actually, I was going to ask the group also, but let me answer Alexandria's question first, and then I'll ask you folks a question. So how would I respond to parents who have concerns about co-administration of vaccines? It's a great question. And I think, what was interesting is that the reason that the CDC and ACIP originally told people to not co-administer wasn't because of data that there was any problem, was because there was actually an absence of data. And what they really wanted to make sure we did as we rolled vaccine out broadly, remember these studies were originally 30, 40,000, 50,000 individuals, but in trying to make sure that they understood, what's the 1 in a million side effect that we need to worry about? What's the 1 in 10 million side effect that we need to worry about? And where you saw this attention to, clots in rare circumstances with the AstraZeneca and the Janssen vaccine, or these concerns of rare cases of myocarditis in immunized teenagers, that the only way to really sift through that and make it a pretty clean analysis was if there was no other variables. And so basically not having other vaccines being given at the same time just made that so much easier. Once you got to 200 million plus doses of these vaccines, I think everybody was pretty comfortable. Okay, we've got enough of a database now. We kind of know what things are looking like. And so that was the major reason that they lifted the co-administration concern. The other is that in many of the trials, they actually did allow co-administration, at least with influenza vaccine, because many of these trials were being done last fall. And so they needed to allow that. And so there actually is data that the companies have that actually showed that there really was no risk of blunting of immune response with co-administration, which is really the major concern usually. And so, that preliminary data was sufficient that they were able to then comfortably lift this co-administration ban. And so I think the answer to parents is that there was really never any reason the co-administration wasn't okay. It was just out of an abundance of caution to not do it initially, just so we understood everything. And now, now that we're hundreds of million doses of it in, it's pretty clear that there's no reason the co-administration can't move forward as it does for basically all other vaccines. We've been counseling patients to get the first, oh, hi, Noel. We've been counseling patients to get the first COVID vaccine they're offered, but some patients want a specific brand. I don't recall a patient ever asking for a vaccine by brand name. What are your thoughts on that request and advice for the healthcare team to address this concern request? So way back in the beginning, when we had such limited supplies, we did basically tell providers and patients, look, we just need you to take what you can get because that's all we're going to have in most places. And most places did get allocated just a single type of vaccine. So, for instance, early on with Pfizer having really, really strict freezer requirements, the state was only able to identify 26 entities around the state that actually could meet those criteria. And they basically selected 8 sites and said, okay, you're going to be Pfizer sites. We're going to then give Moderna, which is a little bit more temperature stable, to these other sites. And so we basically had to ask people, just take what you can get. More and more, now that there's plenty of supply, Public Health Madison Dane County now has been allowing people to actually sign up and choose their vaccine now for a couple of months. And so, personally, I think that the immunogenicity does seem to be better with the mRNA vaccines. And I think it makes sense with a 2-dose schedule, that those do seem to be a little bit more protective. And so I do think that for immunocompromised patients, it is reasonable to suggest to them that they may be beneficiaries of getting a 2-dose regimen. Certainly if people are very needle phobic or you need to get things done quickly, that the Janssen vaccine is very reasonable. But I think the one thing just to make sure people are aware of, especially for young adults and particularly young women, and especially those that may be using oral contraceptives, that there is a slightly increased risk of clots in the Janssen population. And so I think it's reasonable to, and we recommend still that be part of the counseling, regardless of whether they're oncology patients or not, that people discuss the small but rare risk of clotting and coagulopathies in young adults, especially young adult women. So I do think that we're in a position, Noel, where it's reasonable for providers to have those conversations. I don't think you're going to see wide-scale recommendations to the general public about these kinds of things, because I do think that for the general public, there is some benefit to try to keeping it simple with the messaging, so things don't get too confusing. But I do think that at this point, we can start to have those conversations about guiding people towards mRNA vaccines if they are immunocompromised. Hi, Stacy. It's nice to see all these friendly faces or names on the list. Thank you for discussing PVST. PVST. What's PVST stand for? I'm blanking. Post-vaccination serologic testing. This is magical internal public health speak. Thanks. And that boosters are not needed. We received many questions from both clinicians and the public with immunosuppression, the desire to get more than one series. Yeah, this has been, agreed, Stacy, and that was why I wanted to make sure to include this information. I think, to be honest, I think it comes from a good place. I don't think people are trying to be malicious. It really does stem from that solid organ transplant paper that got spread pretty widely in the transplant population, and I think was in some ways overly interpreted, and people are just so eager. But also, this misunderstanding, and we got deluged with calls as well, that people were, because serologic testing was readily available in many places, but it is primarily not going to be testing for the spike lipoprotein. And so, just so many requests, and I really want to try to do everything we can to tamp that down and help people understand that, we need to get through this first wave of primary immunization and get vaccine out for everybody initially. And then we'll get to the point of having conversations about boosters. To be honest, in the beginning, I was, very comfortable saying I thought boosters were going to be needed and were going to be very common. And I've actually started to waffle on that a little bit, that, the immunity actually seems to be quite good. And even though antibody levels do gradually drop over time, that the current vaccines actually are holding up really quite nicely against most of the variants that are currently circulating. And so I think this is really a story that's still being written right in front of us. All of the companies are working very actively, and people are seeing the press releases from Moderna and Pfizer. They both have variant vaccines already ready and already being tested, just in case. And they show that they boost extraordinarily nicely on top of the primary vaccine. And they've also shown that the boost with the original version 1.0 also boosts to levels that are quite good. So I think people should be very comfortable and very reassured that this is all being studied very closely. It's being followed very closely, that everything's sort of ready to go when the time is right. But we really need to encourage everybody to kind of be patient. I think everybody has realized that this whole pandemic has been science in a fishbowl. That it's been, transparency at an incredible level that we've never seen before. And, the daily deluge, as I call it, of COVID information that I'm under, and just trying to stay up to date with all the stuff that I needed to, is a lot. And so I can't even imagine what it's like for the general public who may not have as much scientific acumen in trying to keep up with this. And so I think this is why this network and other networks like it are so important, because if networks like yours with this many organizations can share consistent messaging, it's just so much easier for the public and so much more reassuring, because it's just so much more easy for them to digest when they're seeing consistent messaging from so many different sources. This is one of the reasons that we've been much more active about interacting even with the media and trying to get them all on the same page as well, because I think a lot of the distrust that arose was because people were seeing things that they thought were conflicting information. And so the more we can all do to try to stay on the same page and endorse the same messages and try to, support the public health people, especially, that are really doing the heavy lifting on trying to, collect information, do the surveillance, process that information, and make it digestible for us, for all of us, the better off we're all going to be. And so I do think that we will really benefit if we can be as consistent as possible in how we message these things going forward. Amy threw in a question about, do I have a prediction for FDA approval of an AstraZeneca vaccine? I think it's going to be a while still in the United States. They keep extending the dates. I think everybody needs to acknowledge a couple of things about AstraZeneca and their vaccine. One of the things I think first and foremost is that this is not a company that was in the vaccine space in any great way before this pandemic. They basically had a single vaccine. They had FluMist that they had acquired by purchasing another company, but had never really been involved in vaccines. And the Oxford group that had generated that vaccine, had been working on that vaccine for quite a long time, and there had been plenty of companies that had an opportunity to grab that vaccine company and had taken a pass. And so I think there was always some understanding that, there were potential issues with that model of a vaccine, of using an unproven adenovirus and then a novel way of delivering the antigens with that model. And so I think there's a lot of potential to that vaccine, in that it's, similar to Novavax and Sanofi's vaccines, very temperature stable and will be very helpful on the global scale. But it's gonna be a heavy lift to make sure that everybody's comfortable with it, because it's clear that both the Janssen and AstraZeneca vaccines that are based on the adenovirus model do seem to trigger some clotting issues in certain populations, and so that really needs to be taken seriously. And the immunologic response doesn't give quite as good a level of protection. And so I think it's a vaccine that, while it has some potential benefits, may be better suited for areas of the world where cold chain isn't quite as readily achieved, and where there's more need for easy to transport, easy to provide vaccines. So the other part of that, and the reason it's largely delayed, is because the FDA really has a lot of very strict requirements, which were issued way back in September of 2020, which we jokingly call the playbook, which was basically the description for the companies about what the data was going to need to look like. And I think AstraZeneca was a little bit more hopeful that, since they were early, that they might be able to get a pass on certain requirements, because there was what they perceived as sort of desperation to get a vaccine, and they already had a vaccine ready to go. But what's become clear, and I think has been very reassuring to many of us, is the FDA is serious. They are very clear that they are going to be absolutely strict on the approval of these vaccines, because, as we say often, you only have one chance to make a first impression, and they really need to maintain the public's trust. And so they've really been very adamant that, even under the political pressures of the fall of 2020, that they got together with the pharmaceutical industry and issued a statement in September that said, we don't care what the politicians are saying as far as, Operation Warp Speed and speeding this up. We are going to stick by the rules and the standards that we've set, and have maintained for 30 or 40 years on balancing safety and efficacy and making sure we are absolutely comfortable before we release these things into the wild, into the public. And so they are holding AstraZeneca to those same standards. And, no fault of AstraZeneca. When you're new to this, you have to understand how to do it. They are gradually moving in the right direction and collecting more data and getting the data that the FDA requires. So I am still hopeful for them that, they'll be able to have something ready to submit sometime this fall. And we'll have to just see how it plays out. It's certainly approved in a lot of other countries and being gradually used in more places. And so I think it'll be important on the global scale, but time will tell where it fits into the US market. I think that the Novavax and Sanofi vaccines, the protein subunit models are likely to probably be available even before the AstraZeneca vaccines at this point. I'm curious from your group, if people can sort of share while I'm answering the next question about what you're hearing specifically from the oncology population about what their perceptions are of vaccines and sort of how their perceptions are about the whole mask change and what that's meaning for them. Because I think we're very concerned that left a lot of those populations sort of back into a state of concern and even fear that with only, at best 2/3 of the population in vaccine mode, that there were still a lot of unvaccinated people, and they're concerned about what their exposures were like. What do I say to parents about concerns about myocarditis? Yeah, so I think first and foremost, there's still no causation that's been shown yet. I think that one of the things everybody needs to recognize is that April through October is what in pediatric infectious disease people, we typically joke that this is myocarditis season. That as Lyme disease flares up and as we see enteroviruses circulate, which are basically a spring and summer virus, that this is always the time of year where we see young adults and adolescents with myocarditis. And so one of the things that I think is really important is that association is not causation, that just because we're seeing some cases of myocarditis in vaccinated individuals doesn't necessarily mean that the two things are actually truly causative. And so that was actually the major messaging that the CDC was trying to get out there when there were a few of these reports here and there, was really trying just to encourage people, please report these so that we can investigate them and see if is there actually any association that we needed to know about, or is this just a coincidence? So I think at this point, if it's an otherwise healthy adolescent or young adult, that I think that if they ask about it, I think that should be the answer, that while there's investigation going on and that there's some very low level association, if it is even related, it's extraordinarily rare. I think the one group of people that just need to be a little bit more cautious are people with underlying cardiac conditions, that I think for those populations, at least the mRNA vaccines may not be the best choice. The one caveat is that all of the cases, at least from the Israel series, which is the only series that's actually been published, were people that had both doses, and that it happened after the second dose. So that certainly getting at least an initial dose is a good way to get started. And then we can sort of wait and see how things work out. All right, let me read a couple of these about what people are seeing from their oncology patient. I'm seeing a lot of oncology patients in networks getting vaccinated, whether their family and friends are not. Yeah, that's concerning, Alexandria, because it's almost like our old bubble approach for both influenza and oncology patients and for Tdap vaccines before we were immunizing pregnant women. It was so important to immunize their circle. And I really do think that there's room to grow, and potentially your network can help share and message the importance of creating cushions or bubbles around our precious oncology patients in helping them be protected from things, and really trying to encourage vaccination against friends and for friends and families. Yeah, and I do think that oncologists endorsing these, I know that a lot of oncology patients I know, no matter what I say, they're not going to do it unless their oncologist says so. That there is really such a level of trust and importance of that relationship that I think you all really do have a major role to play in this. And to be brutally honest, I mean, part of the reason I'm here and speaking to you is because I think that the more subspecialists and subspecialty groups that endorse vaccines, the better off we all are, because a lot of people have viewed these as things that are for the healthy individuals, and that have been reluctant in a lot of the comorbidity patients. Noel, almost all of my patients are vaccinated except for a few who ascribe to beliefs about chips being inserted. Caregivers are less likely. Patients are less concerned about masking, most concerned about their immediate family being vaccinated. Yeah, masking equals wish everyone would respect, protect others, and wear a mask if unvaccinated. Yeah, I think in Europe it's been interesting because as they've been lifting masking, it's been simultaneous also with having vaccine passports. That there's much more of a level of willingness to share medical information in Europe, and so I think that lifting masking does go along very nicely with vaccine passports. But this lifting of masking and just trusting that everybody's going to do the right thing here in the U.S. obviously is a little bit of a false narrative, as I think we're all aware. I'm also seeing people with cancer very concerned about, I'm going to put on my old man glasses here for a second, hold on, with return to work when others aren't vaccinated and mask mandates dropped. Yeah, this is an interesting topic that Alexandria brings up, which is the idea of where are we with vaccine requirements. The Equal Employment Opportunity Commission has been very clear on this, that even under an emergency use authorization, that employers actually can require vaccines as long as they allow for medical and religious exemptions. And it has been actually very interesting, and I've been a little bit surprised, to be honest, that as many employers have actually already started moving in that direction with either incentives for people to be vaccinated, including as high as like $500 in some settings for people to be vaccinated. But there are quite a few employers, and you're going to see more and more of them, especially once the biological license are issued, that I do think there actually are going to be quite a few requirements. And I think you're going to even start to see healthcare providers and healthcare systems start to require vaccines, certainly for their employees. So I don't think that story is done being written either. But I do acknowledge that, that it is uncomfortable for a lot of your patients to return to employment and being required to return to employment with employers that aren't going to be able to or aren't willing to require vaccines. And so, the hard part with the masking part is that, currently wearing a mask means that there's either something wrong with you medically or that you're an unvaccinated individual, is sort of what those equate to when we asked a focus group recently, which is sort of unfortunate because, I think a lot of us that are vaccinated actually do still, as kind of setting an example, still wear masks in certain settings. I'll still wear one when I'm at the grocery store or, walking in public places and things like that, as a kind of a solidarity thing for people that are uncomfortable and have underlying medical conditions. But you can certainly feel the eyes on you when you do it as, oh, you're one of those maskers. And so I think we're in a very interesting place historically. And I have a lot of sympathy for immunocompromised and oncology patients as they navigate all this. All right, well, I think I talked enough, and I think we're close to the end of the hour. Oh, thanks, Alexandria, for posting some of the HPV information. I think all of the stuff that you guys have put together is really, really important for people to understand the importance of HPV vaccine. And, again, as we've said over and over again at various forums in the past, HPV in so many ways is one of the most amazing things that's happened in our lifetimes. I mean, it is really something that has the opportunity to be a complete game changer for an entire generation. And, it's been since, the vaccines were licensed in 2006, sad that, even almost 15 years later, still only 60% of young individuals are being given the opportunity to be protected against these terrible diseases. And I admire all of you that are helping spread that word, but this is just such an important battle that we need to keep fighting, because HPV is really such a seminal change in the world of medicine, and needs to be, every kid and every adolescent needs to be given the opportunity to benefit from it.
Great. Thank you so much, Dr. Conway. We just appreciate it. Alex, I'm going to turn it back over to you.
Thank you so much. So before we close today, I wanted to highlight a few resources, and I think Alexandria dropped the links to these in the chat. We do have a couple of really great HPV vaccine resources that you can use. We have this fact sheet. We also have this infographic that you can use. And then we also have our HPV issue brief that was recently released. So if you haven't checked that out yet, I would encourage you to do so. And then just putting in a plug for July's webinar, we will be having Courtney Harris of Covering Wisconsin, and she will be talking about local marketplace insurance enrollment, the American Rescue Plan changes, and then also talking a little bit about some of the resources available through Covering Wisconsin and the Wisconsin Cancer Collaborative. And before you leave today, we would really appreciate if you could take our short poll before jumping off. But other than that, thank you all so much for attending today, and we look forward to seeing you next month.